So let's talk a little bit about the risk of performing manual therapy on the cervical spine. And this is really a deeper look into red flag conditions. And this has typically been associated with manipulation, so that's why we really named it this. But first, let's understand the risks and benefits of cervical spine manipulation, and then talk about what adverse events are and how often they occur, and then talk about how do we mitigate that risk, looking at those who are particularly at risk for adverse events. Talk about some specific absolute contraindications, and how we're going to manage this in this population. So cervical spine manipulation is used by a variety of healthcare practitioners to treat neck pain and headaches, thoracic pain, and upper extremity symptoms. The first adverse event reported in 1907, so people just thought this was inherently an unsafe technique. Some literature suggests that AEs happen with manipulation such as stroke, but this is inherently variable so that the risks must outweigh the benefits. Other literature, though, suggests that thorough evaluation and careful consideration of the screening can help predict and avoid these AEs. So, the most serious adverse event from a manipulation would be a cervical arterial dissection that may lead to stroke or even death. And there's certainly question on whether or not manual therapy is actually linked to this cervical arterial dissection. An expert panel in 1995 looked at the 736 clinical cases that were available at that time and determined that manipulation was only appropriate in 11.1% of those cases, kind of making you think that the assessment should have been more thorough to rule out or find the contraindications for those cases, those other 89% of cases. So adverse events are really anything that happens after a treatment that doesn't necessarily have a causal relationship with this treatment, but it would be a poor outcome. So unintended noxious response under normal dosage of whatever that treatment is. So the definition is poorly defined within research. So they can, adverse events from manipulation are more common with chiropractic manipulations based on the literature that's out there. But there's really a lack of high quality studies that look at adverse events. And because maybe they happen so rarely, at least the severe ones. So cervical manipulation has a higher report of AE than does like cervical mobilization. And this may be due to how they do that technique. Maybe from the patient's perspective, it seems a bit more aggressive. And then the patient's values always need to play a role in your decision making on whether or not you're going to choose a mobilization or manipulation. So what we're talking about when we talk about cervical arterial dissection dysfunction, this is really either the posterior system, so those vertebral basilar arteries, or the anterior system, the internal carotids. The vertebral artery is compromised with contralateral AA rotation, so rotation to the left is going to decrease blood flow on the right. That's a normal occurrence. Okay. So the signs of non-ischemic and ischemic vertebral artery dysfunction. So non-ischemic neck pain, occipital-based headache, maybe there's C5 or 6 nerve root impairment, but that's pretty rare. Ischemic would be, you'd have signs of those 5 Ds and 3 Ns, maybe some ataxia, hoarseness, memory loss, hearing disturbance, photophobia. And you see the pain pattern there on the right. The internal carotid artery, non-ischemic, you see the pain pattern there on the right. Maybe they have Horner syndrome or a pulsatile tinnitus. They may have some cranial nerve palsies, particularly the lower cranial nerves. And then ischemic issues with carotid are pretty substantial. So contralateral face and upper and lower extremity sensory loss, or hemiparesis, speech impairments, or balance disturbance. Okay, here's another description of the pain patterns. That's vertebral artery there on the left and internal carotid there on the right. Okay, so the neck position will affect vertebral and carotid flow. So rotation has been shown in several studies to decrease the contralateral vertebral artery. And at least one study didn't demonstrate any effect with lateral side bending. And even though in-range rotation and or combined extension rotation may be associated with decreased blood flow, there was little evidence for correlation with vertebral artery symptoms. And that's really because we have the circle of Willis that is allowing for blood flow in the other 3 vessels that you're not testing at that time. So we can only really test one of those at a time. And if there's good collateral flow, then you don't have any symptoms. Okay, back to adverse events a bit. There are poor definitions in the literature. So they name them often either mild, moderate, severe, or catastrophic, but there's no definitions of what is mild versus moderate versus severe in the literature often. So common examples of AE is like muscular soreness, an increase in pain, and maybe the increase in pain is by 2 points, that would be mild, or maybe it's 4 points of moderate, but it varies from study to study. So it's hard without a common definition to say how common are those things. So, but significant adverse events are really rare, occurring in like an estimated of 1 to 100,000 to 1 in several million. So and often we believe that the chances of AEs can be minimized through by thorough screening and frequently assessing those symptoms during and after treatment. So here is a chart from Puente Dura, and there's absolute contraindications there on the table on the left. And then here are some other red flags that you need to be aware of that may be leading you to believe that there might be some cervical arterial disease going or dissection ongoing. So those would be things to be looking out for there on the right. Okay. So you must be aware of the subjective signs, asking the right questions, and must perform, your body chart. What does this look like? Do a red and yellow flag screen for every patient. The clinical practice guidelines tell us to do that. And the fact is that may not have been done before the patient came to you. So early recognition is crucial to avoid any complications from that. There's a lot of talk about cardiovascular risks, and we need to be paying attention to that. Cardiovascular issues like high blood pressure, hypercholesterolemia, or smoking may affect the patency of the vessels and therefore make it more likely that a CAD would occur. So often patients that already have migraines and they're having some sort of dissection will report that their headaches or migraine are very different than what they've had in the past. So there may be some signs of, there may be some neurologic signs or ischemic signs, so Horner syndrome or cranial nerve palsies, particularly the lower ones like swallowing, so asking about any trouble swallowing. And patients often fail to report these neurologic or ischemic symptoms, and we talked about this before. They just don't think you need to know, or they don't think it's related to physical therapy or what a physical therapist does. So you may have to be very pointed in your questioning. So the dissection, a tear or hematoma in the internal carotid or vertebral artery, and this is the most catastrophic and is often publicized when this happens from a cervical spine manipulation. This accounts for 25% of all ischemic strokes in people under 25, but only 2% of all ischemic strokes, period. So it's more common in men 35 to 50 years. It's rare over the age of 65. And it can occur spontaneously or due to a minor trauma, so like a fall or a car accident, even a minor one. But this, even when a hematoma or something happens, it doesn't mean an ischemic event will happen. So it depends on if the blood supply is critically reduced. So these things can even be asymptomatic or cause minor symptoms or even heal on their own. So it's difficult to determine exactly the true cause because it may be delayed from when the inciting event happened. So we need to make sure we're screening adequately. So like we mentioned, it may happen from mechanical trauma, but also thinking about infection or pro-inflammatory state causing just anything that would cause a weakening of that arterial wall. So common events may be a rotation or a hyperextension injury of the cervical spine, or even increased intrathoracic pressure. From the internal carotid's perspective, this may be anything that movements, sudden neck movements, or compressing the internal carotid against the body of the transverse process. You can think about maybe some whiplash, maybe a movement that hyperextension that would kind of stretch the internal carotid over the transverse processes. Okay, Thomas, this is a 2016 paper that looked at risk factors for CAD. So they took these 24 participants and they would match them. They had an age match cohort to look at risk factors. So 71% of those participants, now it's only 24, with dissection reported a recent history of a minor trauma or strain. And among those, almost 70% had TIA features in the month prior to being admitted for their dissection. And this study found that cardiovascular risk factors were uncommon, with the exception of migraine. Okay, so things we might see: some balance deficits, ataxia, syncope, drop attacks, dysarthria, double vision. Dizziness really is only reported in 50% of those cases, and many of these symptoms are transient, present days or weeks prior to the event, but they're not understood or reported by the patient, and we talked about that they may not think it's important to tell you about, or maybe they just don't relate it, or they don't think about it. So, asking pointed questions is helpful. The table is very nice here, detailing out the early presentation and late presentation for internal carotid, your vertebral artery, and then also upper cervical instability. There's often, some will promote the use of premanipulative VBI testing, and that's really putting the patient in the position of your manipulation and holding them there for 10 seconds, taking a look at their eyes to make sure there's no nystagmus or anything weird, like some ptosis or anything like that, and before you do the manipulation. So the specificity is okay. The sensitivity is really not there, about like flipping a coin. So the authors really do suggest focusing on the vascular risk factors rather than physical testing for, making you comfortable enough to proceed. So you need to take a look at both subjective and objective data and refer out if you're suspicious. This was another systematic review done by Thomas, this one in 2019. So just talking about positional test, originally developed to look at the vertebral artery flow. But vertebral artery flow is variable for everyone, so we really should consider that testing is testing for the adequacy of the collateral flow, so the other three pipes that are going up to the brain. So positional tests really shouldn't be considered a test for arterial integrity of the one that you're testing, but rather that collateral flow. But they need some more research before you just prematurely abandon the positional testing. The IFOMPT has developed a framework for manual therapists to avoid, to help mitigate the risk of a CAD happening from manipulation or mobilizations. So this really highlights that there's really not one test or a set of or questions that you can ask to really eliminate all risk of CAD. So recommends that you follow a multi-step process. We'll go through that. So at first is identifying risk factors. So here are some risk factors known for cervical artery dissection. Here are some risk factors for upper cervical instability. And then thinking about planning your exam, is there any further patient history data that you need? Are there precautions or contraindications to your manual therapy? Which and what physical test should be included, and what is the priority of those tests? And do any of your other tests need to be adapted? So in your physical exam, these may be some things that you include. Also, be mindful of the progression of vigor in your physical exam, which we talked about in the lumbar spine and we'll continue to talk about in the cervical spine. So this is just an algorithm of the process that they've outlined. So getting your data from the patient history, putting that through the evidence-informed knowledge that you already have, and then planning out your physical exam, those we just talked about, and then your data from the physical exam, using best evidence to analyze those in your own clinical reasoning. Is there any gaps in the data that you need? What is the quality of the data that you got? If someone is highly irritable or they have a high degree of central sensitization, then those things may not be as clear. And then making your decision on your action. So, of course, keeping the patient values, and that's a shared decision between you and the patient. So the decision made at each step really influences the next step. And so this is just a decision tree process outlining what we just talked about. So manual therapy and cervical arterial dissection, 4 ways that manual therapy can cause that. So maybe the force of manipulation damages the arterial wall. If you use manual therapy and there's already a dissection in progress, remember we talked about the patient may have been having this go on and have had symptoms for the past month even. And so if you do some manual therapy with an existing dissection, then that may cause some of that material to break off and go to the brain. The position in which the manipulation or manual therapy techniques are performed may alter blood flow in the arteries. It may cause vertebral arteries vasospasm, temporarily causing a change in blood flow. But that's never been demonstrated in a live case. So the risk versus benefits. So you really should not deny patient potentially beneficial treatment based on if you've determined that to be a low risk. So if the decision framework below at the bottom has risk on this left column, benefit, and then action. So obviously if there's high risk and even low to high benefit of manual therapy, we should avoid that treatment. Even if there's low risk of when there is, in the cases where there is low or moderate risk and the benefits may be low or moderate, maybe you treat them and just pay a lot of attention to continual monitoring, reassessment. If there's moderate risk, then perhaps we choose to treat in an area away from the cervical spine first and just reassess as we go. So maybe that's a thoracic intervention or something. So in conclusion, CAD is the most severe risk factor and AE associated with cervical manipulation. It's certainly not the most common. That's an error. And CAD commonly presents as something that's moderate to high severity, usually acute-ish onset of neck pain and different from any other headache that they've had. And it may be a result of minor mechanical trauma. So making sure you're paying attention to that. The prevalence is low, but that consequence is severe. So it's not something that we want to be pretty cavalier about. Positional testing, not really particularly helpful for us. And we don't want to deny benefits of manual therapy to all people with neck pain and avoid missing some really good treatment effects from that. So pay attention to subjective, objective signs, reassess during your treatment, after your treatment, between treatments to avoid any adverse